I've already provided evidence that the prevalence of diabetes within care homes is high. Other studies have demonstrated that residents with diabetes often have significant comorbidities and have higher risks of cognitive impairment and dependency. I would like to review some of these findings, which provide a platform for the work of the Diabetes UK Task and Finish Group on care home diabetes, which I had the pleasure of being involved with, and which led to national guidance in this area. My contribution here is designed to complement Lynn Murphy's chapter on care home diabetes. This slide summarises two retrospective chart review studies from the United States. The first study, shown on the left, demonstrates that diabetes increases the risk twofold of subsequent admission to a care home of housebound patients. And the study on the right of subjects previously admitted with heart failure to hospital had a six-fold increase in the risk of subsequent admission to a care home. Here we see data from a diabetes screening study of care homes in Newcastle, England, showing that high prevalences of diabetes can be found in both standard and EMI residential and nursing homes. In this study, the investigators found a high prevalence of undiagnosed diabetes in dementia approaching 13%. This and other studies provide support for screening for diabetes at the time of admission of a resident to a care home, irrespective of the type of care home involved. In the South Wales Care Home Diabetes Study, evidence was provided that diabetes residents, compared with those without diabetes, had a greater risk of being cognitively impaired, as measured by the Mini-Mental State Examination score. This is shown on the left in the black columns, and a greater likelihood of being more dependent, as shown on the right in the black columns, using a behavioural rating scale. This slide shows data from two US studies of nursing homes, which confirm data from several UK studies demonstrating that residents have a high mortality rate, often experience pain at the time of admission to a care home, have a high rate of admission to hospital, have a high rate of cognitive dysfunction and pressure sores. These high rates of comorbidities are also associated with high levels of medication use. With this background of evidence about residents with diabetes, it is not surprising that Diabetes UK, supported by NHS Diabetes, the Royal College of Nursing and other key members, decided to organise a revision of their original 1999 BDA guidance of diabetes care within care homes. This slide shows the mission of this review, the membership of the working group, and lists other individuals who helped to prepare the revision. One of the key outcomes of this revision work was the opportunity to developing guidance for care home managers on how to create a policy of diabetes care for their homes. The important areas to include in a policy are shown in the diagram and include a diabetes screening program, management of hypoglycemia, referral to hospital, and audit. The policy template is designed to stimulate other areas for development within the care home, such as training and educational initiatives for the staff of a care home. Another important outcome of this work at Diabetes UK was to develop the basis for an individualised care plan, sometimes referred to as a passport. This documentation is considered crucial to promoting effective diabetes care and allows outcome data and audit processes to be examined. All residents with diabetes should have a care plan of this nature. National guidance based on the work of the Diabetes UK Task and Finish Group is now available on the Diabetes UK website. I urge you to read it, as it provides an up-to-date account in depth of diabetes within care homes. Diabetes care within care homes is an important challenge for any health or social care professional, but it can be rewarding if this care is of high quality and pays attention to the unique aspects which have been demonstrated in this DVD.